Good morning, Carbon County. Thank you for joining us for this morning's Physician COVID-19 discussion panel. With us today, we have Dr. Edward Zimmerman, Dr. Dwayne Abels, and Dr. Greg Johnson, who will be providing some current updates regarding COVID-19, and then we will move into questions from the viewers. So please be thinking of those questions, and we're happy to address those. With that, Dr. Abels, I'll let you start.
Good morning out there. This is COVID-19 committee on Facebook Live, I guess. But we still only have 9 confirmed cases in our county. We do, of course, have some current testing out, but so far we've not had a cluster outbreak that could have occurred because of effective tracking by Christina Baugh and the Public Health Service here in the county. We did contact tracing aggressively, and fortunately everybody was negative or quarantined appropriately, and that was about 3 weeks ago, 3.5 weeks ago, and that outbreak did not occur, fortunately. It could have, because it was in a closed, high work environment. And so far at the hospital, we've not had any people, healthcare professionals, come down with this illness at this point in time. The ER has been busier, the ambulance has been busier. We are in phase 2 of our surgery. So we're working, trying to get care of patients. The problem with my perspective on the COVID-19 is that because of the COVID-19, I worry about a lot of other patients out there that have not gotten necessary care. If you look at the data across the United States, ER visits are way down, and as a result, people have stayed at home with heart attacks and strokes, and so that's not always good, of course. We're moving toward phase 3 in our surgery over the next week or two. So what that means is that we are able to do much more complete orthopedic surgery and general surgery in our facility.
So the majority of that with phase 3 is surgeries where people would need to be hospitalized after the surgery for a day or two. So things are moving forward. Luckily we haven't had a surge or outbreak, but still want to remind everybody that this is far from being over. I read one report last night that Texas has had an increase in hospitalizations. They're actually at maximum of what they've had throughout the outbreak. And they were one of the first ones to reopen businesses and such. So it'll be interesting to see what happens going forward with that, as well as all of the social unrest. Obviously, there's a lot of people that aren't distancing in that regard. A lot of businesses are reopening. Once again, be patient with all of the restrictions that all of them face. It's very frustrating for restaurants, hairdressers, basically all of those type of situations where they have to alter their seating or not have people waiting in waiting rooms, that kind of thing. Same thing goes for the hospital. We're trying to move forward, but it's frustrating for patients and us alike. And
currently we're reviewing, and with the clinic, we're phasing in the clinic gradually back to 1 clinic. And of course there will be, if somebody's sick, there will be special rooms allocated at the clinic to be seen, so we protect the public and things like that. But they're also going to start selectively looking at bringing more patients in rather than Zoom, because the clinic has remained clean, and so far we've not had any contact spread from the clinic that we are aware of. So things will improve in patient care, because lots of times, of course, when we have older patients, it is always helpful to have a family member there with them to improve their care. So we're working rapidly to doing that so that we can get the family back more involved with our patient care.
And on a state level, we're still doing additional testing, and we're averaging about 4 new cases a day. So it's not like if we aren't getting some cases. We still have 760 total. We have 18 deaths in the state. So, and we still get new cases every day. So it hasn't gone away.
This disease has not gone away and will not go away, it looks like. The last thing I read last night was that with the R0, which is the spread number of this disease, we would need herd immunity of minimum of 80%, 75%, some people say. And the highest herd immunity so far in New York is only 25%. So this disease still is circulating. We do not have herd immunity.
So I was just giving a note here that we have a positive test that came back this morning.
Just this minute, it looks like.
Yep. So we don't know more about that. Christina Baugh, the infectious disease coordinator in public health, will investigate contacts and do the back tracing with that if necessary or appropriately.
And in fact, as this was a small cluster that was identified and aggressively tested by public health in Christina. And that's how we discovered it. And fortunately, people came forward and reported symptoms, which is always important. We don't know anything unless you guys tell us you have symptoms. Call the clinic, make an appointment at the family practice clinic or with Dr. Young. Dr. Young, I believe, has swabs now too, he told me.
And so if you do get a comment or a call from public health or Christina, if they're doing the tracing, just try to be cooperative. Nobody's trying to make anybody's life more complicated by doing this. It's not pointing fingers. It's just trying to be responsible and try to isolate people that potentially would be contagious or infectious.
And fortunately, the hospital ordered multiple additional tests so that we now can finally start swabbing more people in these clusters and things more aggressively. As people unfortunately remember when we first started this, we quarantined people. We had 20 swabs in the whole hospital. We could not do anything to try to see if you're sick, try to get you back work sooner. Now we have the hospital ordered 900 swabs in, so now we can now start testing more these clusters and being more effective in our treatment as far as screening, isolating, controlling the disease. And then if somebody has the disease, we educate them on what to look for so that they know when to come to the hospital so that we can treat them if they need to be hospitalized.
How quickly are results received once a test has been done or a swab has been done?
It varies from the state. Sometimes, depending on the volume at the state, we'll get the test back in a few hours. Sometimes it's 3 days. It used to be a week, but they've markedly improved. So I got to give the state credit. They've stepped up, hired more people, gotten their testing program much more organized. The longest that we've had is 3 days. Is that correct, Christina? 5.
But the state's prioritizing too. I mean, if it's like from a nursing home or from the hospital, it's like 24 hours. If you're not symptomatic or not much for symptoms, you're low risk in maybe a couple of days.
If somebody is acutely ill, then we do have the ability to do a point of care test, the Abbott test, if you've heard of that, and we get those results back in about an hour. But we're still trying to reserve that for significantly symptomatic people, ones that need to be hospitalized or ones that are potentially a risk in the community setting, caring for elderly parents as an example, if they have a compromised immune system. So there's some patients that we do use the Abbott test on, and then we send the confirmatory test to the Wyoming Public Health State Lab.
And and we would like to do more random screening, but right now we've not gotten a release from the state lab to be able to do just drive-by screening at this point in time, as far as volume is concerned with the state lab, at least the last time I read their guidelines.
As far as I know as well, the antibody tests, I don't think anything has really moved forward as far as recommendations or feeling that antibody testing confers immunity, either short-term or long-term at this point. We still don't have concrete information on that.
No. And in fact, the problem with the rapid release of the antibody test, it's hard to know how accurate they are at this point in time also. I know it doesn't make much sense since tests were released, but tests have to be tested also.
So if we have questions regarding screening, who can we contact within MHCC?
The clinic is doing the majority of the screening, so the Memorial Hospital Family Practice Clinic. And we can get you, well, can we maybe get that phone number up here?
Yeah,
before we sign off?
Absolutely. That phone number for the MHCC Family Practice Clinic is 324-8494. So please feel free to contact them, as well as our COVID hotline, which is 321-5767. So both of those are good options.
And with the new testing and the screening, we're trying to set up a plan for screening, but the screening test will be accompanied potentially with a fee. The Wyoming state tests are free. And so that's the difference. And we'll be working toward that now that we finally got these swabs just like 2 days ago.
Mm-hmm. Now, is there going to be, I realize that we don't charge at all for the testing, but
well, that's the state health.
Right. But I'm not sure if there's going to be some kind of administrative or collection fee associated. So I don't want people to come up and be tested and then if they receive some kind of minimal bill, I guess I'm uncertain about that, but that should be clarified.
Yeah.
When we say that it's free.
It's not free. It's the only time that is no cost to the patient is the test that goes to the state health exam. If we start doing screening tests, they will go to a private company and there will be a charge associated with that. Unless the state has enough capacity, we can start screening in this area. But right now they don't have the capacity to allow screening widespread. Unless you know something different, Dr.
No, that's what we've been following too.
Since he's the public health officer in another county.
All right, so I've seen contradictory information between the World Health Organization and the CDC regarding asymptomatic patients. Can you speak about that, please?
We see that discrepancy as well.
Yeah.
So,
And Dr. Zimmerman has a note on that.
Yeah, so that comment came out yesterday morning. It was kind of offhand remark at a press conference, and they retracted that by that yesterday evening because we know there is asymptomatic spread. It is not the primary source of spread, and that's kind of what that person was trying to say. You're primarily going to get it from droplets from other people that are probably actively ill. The people that do not develop any symptoms, though, still can spread it. And I have personal experience in a nursing home where it went through like wildfire, and most of the residents who we tested positive had no symptoms that recovered and turned negative and never developed symptoms. At least this is in a high-risk elderly population. So we know that it's even more prevalent in the general population of healthy young people just not having symptoms, but still being able to spread it. And that's why we do recommend masks, not because it protects you, but if you happen to be a carrier of this, it will decrease what you can spread to others.
Yes.
So unfortunately, it hit the headlines promptly when it said that we don't have to worry about asymptomatic people. But when they retracted it, there weren't headlines mentioning the retraction of that. So.
Do you recommend employers require their employees to wear masks?
Yes. Most
Yeah.
aren't.
Yeah, it depends on the situation.
It depends on what kind of the job is.
Yeah. I mean, if you're working relatively isolated or not in contact with the public, not in close proximity to other people right where you are, then I think using some discretion. If you are in direct contact with the public, I'm certainly in favor that you wear a mask at all times.
And the original recommendations were to wear the mask out in public if you're unable to maintain the social distancing.
Mhm.
So grocery stores and such as that, where you really probably will not be that far away from people, is the places to wear those masks.
So I think we should all still wear our masks and encourage general public to wear your mask when you're out in public, and shopping and that kind of thing.
And all of us wear our masks when we're out and shopping. That's all I can tell you is I do it.
Yeah.
Because I wish to protect other people in case I'm an asymptomatic carrier for some reason.
Yeah, if you're taking a walk or working out in your yard and that kind of thing, then it really doesn't serve any purpose. But
Especially with the wind here.
yeah, in contact with other people, I think it's respectful of other people to have a mask on.
Okay, so going back to MHCC and some of the parameters that are in place, where is MHCC at in terms of returning to business as normal? And do you foresee them removing some of the restrictions that are currently in
Well,
place?
yeah, I don't think I can't foresee returning to business as normal.
No.
Meaning that employees and people entering the building are not screened in some way. So this is always going to be in the background going forward, or I guess until there's a effective vaccine. But we're trying to move forward. We've moved forward from the surgical standpoint, made great strides with that. In our meeting on Tuesday, we talked about easing restrictions for visitation. We're going to have a vote on that next Tuesday, and I think that we've reached some clarification. It's still going to be restrictive. It's not going to be back to business as usual as far as people just coming and going as they please. But say in the ER, being able to have one family member or one visitor, we're striving to do that. But it's going to be with some restrictions that the visitor wears a mask, stays at the bedside with the patient. It's not where you can tag team with other family members or other people of interest. So it's not going to be business as usual, but great strides going forward.
Yeah, instead of no visitors at all, we are working toward getting reasonable visitation and protecting the public and the staff as much as possible while we're doing this. For instance, like I said, we're going to require people to wear a mask. You're going to have to wash your hands before you come into the facility, and before you, not before you come into the facility, but when you get to the facility, when you go to the room, you're going to be required to wash your hands thoroughly. Things like this, simple things that are a pain, but we've got to do it to try to protect everybody as much as possible. And that's the reason that we've always had some visitation for some serious problems, because we understand that patients need full care, which means family support, not just us. We're fully aware of that. And this is why for the floor and other things, we are going to try to ease these restrictions, and hopefully we don't have a surge, so we have to revert back. But that's up to the public to help us do that out there, to help us prevent that surge, so we can continue on this path. But I agree with Dr. Johnson. Unfortunately, until we get a vaccine, I doubt any hospital is going to return back to normal. What quote unquote normal used to be 2 years ago.
And try to keep in mind that I know it's frustrating for patients and family, but it's immensely frustrating for us as well. We want to move forward just as much as anybody else. From the ER standpoint, the number of times that I go out to the parking lot and talk to family members in their cars or outside of the ER, it's a huge inconvenience for us as well, and has an impact on how we're able to care for a patient if we're running back and forth and such. So we want to move forward as well. So don't think that it's that we're just indiscriminately trying to keep people out of the hospital. That's not the situation.
Okay, so you spoke about phase 3 for surgeries. Do you know when do you know when they will increase the number of injections being done a day from the pain management group? I've been told that instead of 12 injections a day, the pain management group is only doing 6 at this time.
I did not get any data on our last meeting from that.
I mean, I can't comment on that.
I think it's just 6 for the time being.
Is that
Because
just
of
because
spacing.
they're backed up, or?
No, it has to do with the phase, it has to do with being able to keep patients separate and safe, and having too many people congregate in one area at one time. So, and it has to do with PPE.
Yeah, and the pain clinic has also decided that's the safest thing for them to do for their patients too. So we'll be interacting with the pain clinic, but hopefully with phase 3, that was briefly discussed, and we'll be talking about that more on Tuesday to try to increase that, because I have several patients from Hannah that would like to get in also.
So phase 3 is probably is really realistically the end of the line as far as the surgical phases at this point. That means that they can pretty much do all procedures, but they do have to keep in mind the PPE and the ability to distance patients. So that's going to be staying with us for the indefinite future. But so at the pain clinic, if they're limiting it to 6 injections, as we go into phase 3 anyways, I guess that would be a manifestation of the time element and being able to keep people adequately distanced from others.
And with the visitors coming into the hospital and stuff like that, this is also going to stress the distancing in the facility. So all these things are combined. So we're trying to keep this all in balance, because if we allow more visitors in, that means our space for visiting is still the same. So does that mean we will not be able to be as aggressive to open the pain clinic? That's something we have to look at. And we're going to still be meeting every 2 weeks after this week. And we were meeting twice a week, once a week, now we're meeting every 2 weeks in the steering committee. And we'll be continue to look at these things. And this is the input we want from the public, so we can help decide that with the public's in talking to us too, believe me.
Well, one other thing from a public standpoint, as we go forward and try to open up patients having a family member or somebody with them, even from the standpoint of X-ray and laboratory, trying to allow that, but if you're familiar with the hospital, the waiting rooms that were an X-ray laboratory, those kind of things will not be used. We still cannot use any of the waiting rooms. That means up in the ER, X-ray laboratory, the waiting room upstairs for inpatients. Those are still completely unusable.
All right, so I am 9 months pregnant and was told that my spouse and I would have to take the COVID test before I give birth. We do not want to take the test. If we refuse, what would be the outcome?
Well, congratulations. I don't have an answer for that. I guess
Dr. Cunningham's not here today,
yeah,
unfortunately.
Dr. Cunningham isn't here. But our infectious disease coordinator, I guess, it would be. discussion with her and with Dr. Cunningham.
And also the question of maybe want to discuss why you wouldn't want to be tested in the first place. There may be some misinformation there, some confusion about the test or what it means.
Because the test only means that we need to know the test to protect the baby. That's why we want to know the test, protection for the neonate. And the test doesn't restrict your care. It just says we got to pay more attention, follow up with you more carefully if you happen to be positive.
So on that, we would encourage you to please reach out to the Women's Health Clinic and Dr. Cunningham and for further information on that. Is there any further information on antibody testing results? If someone has had the virus, can they get it again?
Nobody knows in the whole world for sure. That's the problem with a new virus. Until we are into a new virus for a year, maybe even 10 years sometimes, we don't know how long the immunity lasts, if it lasts, if there's any immunity at all, even if you have the antibody. It's hard to understand, I realize that, because medicine before this all happened was pretty straightforward and clean cut. We had the influenza, we had a vaccine, we knew how to treat it, we knew how it was going to act. This is a new, novel virus. We have no idea how it's going to act. No matter what you read in the newspapers or anything like that, we have theories, ideas, but we have no real facts. I'm sorry.
And the vaccine, if they develop them, will have better antibodies than what you might be producing on your own. That's why we're hoping to get a vaccine.
And in fact, the vaccine is my biggest hope for all of us.
All right, so
I read, unfortunately, I read one report, not a medical report, but just a survey of the number of people that would take the vaccine if the vaccine came out immediately. It was kind of surprising how few people would even be interested in having the vaccine. So anyways, I would encourage people, as soon as we get a safe vaccine that's been tested to be safe, I'd be the first in line to get it.
I
encourage other people to do the same.
When hepatitis B vaccine came out, I got the first batch that got to the hospital, even though everybody's afraid of that vaccine. And it's that vaccine prevented a lot of cirrhosis, a lot of livers in the world.
All right, so we have another pregnancy-related question. Are pregnant mothers allowed to take their spouse to their appointments at this point, or is it still only the mother for prenatal appointments?
I will say the plan is to allow the spouse to the OB clinics.
But has that decision been made?
It's going to be made on Tuesday.
Thank you.
But that is one of the areas that the clinicians felt very strongly. This is all these things are family things. Family is important to any process, including a non-disease process like pregnancy.
So Dr. Cunningham was very much in favor of doing that. So unless there's something very, very drastic between now and next Tuesday, I would anticipate that we get a favorable vote on that.
If you test positive, how long can you stay positive? And does this mean that you are still contagious or just when you have the symptoms?
That's a difficult question again, but a good question again, unfortunately for us. The thing is that apparently you may test positive on these tests because they look at a certain segment of this virus on that swab. And that test remain positive after the patient has recovered. And there has not been adequate studies to know if these are pieces of virus or live virus or just simply dead virus hanging around. Doesn't even tell you if you're still contagious. And I don't want to, this doesn't make any sense again, we just don't know. So most of the recommendations now is that if you have two negative tests after disease, or et cetera, you're negative. If you continue to be positive but asymptomatic, we don't think you're infectious.
And in general, we're not retesting. If you have a positive and you've got 72 hours, your fever's gone, you're not taking any medicine for that, and the other symptoms are improving, that's considered a resolution of the disease.
Yeah.
And so we generally aren't retesting these people.
And we're releasing you back to your world. But once again, you guys out there have been reading all these newspaper articles that we see too about this persistence. And once again, it is true, we're looking at it, but we just don't know it and any answers. Right now, we're following the CDC guidelines, which is you test, you're quarantined, you got these parameters. Once you meet these parameters, you are done.
And the parameters again are 72 hours without a fever, without taking Tylenol, I'm looking for it, and then an improvement in your other symptoms, and that's considered a resolution.
Over 7 days, right?
So,
Or 10 days.
7 days since onset of symptoms, or 10 days.
They keep changing it, 10 days now.
yeah.
So anyway, all of that's frustrating for us as well by nature. We like numbers, we like percentages that we can give to patients based on research articles that have been gone over with a fine-tooth comb. Anyways, we're unable to give that information to patients, so distressing to us as clinicians.
It's just like New England Journal of Medicine and Lancet, the biggest, most prestigious journals in the world, had to retract an article that they published because it was not adequately peer-reviewed and the data was completely inaccurate. And this publication led a charge to do this for about 3 days, and then they found out that the data was wrong because, unfortunately, not all researchers are as honest as they should be.
And so the jury's still at hydroxychloroquine as far as early use for prophylaxis. That may be a question that comes up, but yeah, we don't know. We just don't. It's not particularly effective if they're already really ill. There's some studies going on, and a big one in Australia, about using it for very early disease,
Right.
but we don't know yet.
But there's no data yet.
No data.
We're, in spite of the newspaper article, we're not jumping on it.
Can you tell us anything about the new cancer drug Calquence that they are using in Colorado on patients that are on ventilators with COVID-19?
Not me, no.
I've not read any data on that, sorry, I'm guilty.
Do we currently have any patients hospitalized at MHCC with COVID-19?
No.
Does your blood type affect your response to COVID-19 or predict if you will get it?
So
We were
20
talking about
yeah,
that
we were talking about that,
before this
So
morning.
23andMe, where you do little cheek swab and send it into them, they took all their data and looked at it, and they thought there was a small reduction in people who had type O blood and getting the disease, but I don't know that this certainly has not been published and peer reviewed and subjected to the normal rigorous review that these studies would get. So we don't know right now, but that's what the news media was reporting.
Yeah, so it's just an observational thing that's non-scientific at this point.
Exactly.
And that's the problem, is that with anything in medicine, unless you have adequate studies, and I mean rigorous studies, you can have a study where, like recently, it said this was going to happen, and that's part of the Lancet article. They said we're going to do this big study and get all these numbers, and then they picked out, this is what happened. That's not a randomized study. They picked a point out of this study and decided that was the study. It's hard to explain, but when you're looking at events, if you have 10 events, is it real in science? Did the dinosaurs die with that meteor strike? Yes or no? You have to study it a long time, then it's still only a probability. If they would have said it was this, and this selected it without looking for data, that's random. So if you open your study big enough to multiple points, it may appear a random event is real, but it's not, it's a lie.
So that kind of situation where it's called data mining, where you just get a lot of information and then you go through and try to figure out what we can conclude from that. And that's where you have to be very, very careful about conclusions, or you should not make conclusions. That should be an observational situation that piques your interest, and then to potentially develop a study based on that to prove or disprove if there is a direct correlation.
Because people out there are familiar with Narcan, with our opioid crisis now. Narcan was going to save everybody's life in sepsis by this huge study that showed wonderful results, and then in 2 years realized it did not work, even though that was a good study. That's what happens in the endeavor of studying medicine.
I've seen news articles that state they now believe China had the disease as early as October or September. Is it possible that when I was sick and did not test positive for the flu, that I may have actually had COVID-19?
Where was your location? Is
Yeah,
the
if you
question.
travel to China, I guess it would be a
Yeah, it's a
possibility.
possibility,
but,
yeah.
So being in the States.
Unlikely.
Very unlikely.
So the first in the States was January, right?
Well, documented, and there's been some retrospective autopsies that showed probably occurred potentially in December.
So October seems a little far back for that.
Yeah, in California. That's all the data I got anyway.
Some stories are saying that ventilators are not good for patients with COVID-19. If that is true, then why are we putting people on a ventilator?
We're not very often. Usually not. How's that?
Yeah.
And we go to great risks or great lengths to prevent being put onto the ventilator proper. And that changes our numbers. So now the ones that are being put in the ventilator are the sickest of the sick, and so the numbers look even worse for that group because we're using all kinds of non-invasive ways of keeping their oxygen levels up.
And anytime a patient is put on a ventilator, even with bacterial sepsis, all these diseases that have been going on for a long time, ventilators save lives, but they also induce some harm. It's a balance. You're walking a tightrope. So yes, we put the ventilator on because if we don't use the ventilator, the patient will die. We improve their chances, but certainly ventilators have always been somewhat harmful to everybody. People didn't realize it until this disease occurred in the public. Would that be accurate, guys?
I agree. Yeah, I mean, yeah, so with the pathophysiology of COVID is a little bit different as far as the respiratory care, say compared with pneumonia, COPD, traumatic situations and such. And so other situations of trauma or diseases, there are situations where we'll intubate somebody for a short period of time to protect their airway. In COVID, it has turned out that intubation should only be used as a very last resort, where everything else has tried to be done medically to have an adequate amount of oxygen in somebody's bloodstream to keep the other organs alive. So it is always a balancing act, weighing the benefits versus the risk. We never are nonchalant at any time intubating a patient, but has turned out to be a little bit different in the COVID situation.
It's because in spite of the initial data coming out of China about this being a lung disease, we have discovered through our studies in the United States, this is not just a lung disease. It's a multi-system disease, which makes the ventilator not as effective also, which is part of the data looking like it harms more patients than it does also. See?
And so when you read the information, dismal statistics of somebody being on a ventilator with COVID. Well, taking a look at it the other way, it's only the people that are basically have deteriorated to the point that they would die without being intubated. So they're the worst of the worst. And so not unexpectedly, the data is going to reflect that they don't have as good outcomes as people that haven't progressed to that level.
So that's why we set up a guideline in our hospital that we delay intubation step by step to step as long as absolutely possible. And the one serious patient we had, we then transferred to a tertiary care center appropriately, because the patient failed everything we could do to prevent the intubation.
Is the mortality rate higher for seasonal flu or COVID?
COVID. If you look at the percentage of cases versus total number of people infected, would you guys agree?
Yeah, it's still double, at least double.
Yeah.
I mean, that's the information that we have right now. Once again, going forward, as they do more and more testing, realistically, it'll take probably a couple of years to sort out when there's not any restrictions on testing, to find out the actual virulence of the disease process. Same thing happened back with SARS and other infectious disease, new infectious diseases or novel ones in the past 20 years. The initial predictions of death rates or virulence after a couple of years were different. It turned out to be different than the initial projections.
MERS was 15% death rate,
Yeah.
but you couldn't hardly catch it. I mean, it was
It
not very
spread
transmissible.
easily.
Yeah, but if you did catch it, yeah, it was really
Yeah.
bad.
And some parts of the world, it went up to 50% mortality.
Yeah, so, but it was very difficult to catch. So as
This
opposed
is
to this
easy
one,
to
which is
catch.
easy to catch. Yes, yeah.
Can you explain the new multisystem inflammation disease being found in children? What should we look for?
So chances of us seeing are not very high. Just the number of pediatric patients that actually even develop symptoms is so incredibly low that the chance of us even having a case like that in our county is extremely low. But anyway, so you have to kind of take it to the big picture when you hear about these headlines.
Yeah.
We've had no pediatric patients at all. In our state, we've not had any pediatric patients. So you have to look at the bigger picture when they come across with the rashes they were talking about and now this inflammatory response syndrome.
Yeah, if your child has a fever, it's like any child has a fever, it needs to be evaluated. But the cough and all these other symptoms are not very specific, but these rashes that they can have, or the toes that turn blue and purple, a rash on the hands and the soles of the feet, those are things that are very concerning and could be a state of this inflammatory disease. But usually these children also progress with this fever fairly rapidly and then look sick to the parents. They appear ill, not just your regular cold with this inflammatory type disease. But the big thing is that toes turning blue, fingers swelling, turning blue, this rash, redness on the soles and feet seem to be the major rash that is seen with this particular syndrome. But it's not 100%, it's only about 80% with the syndrome.
But from a parent standpoint, you're going to know that your child is very, very ill.
Yeah.
I mean, there's not going to be any question of thinking that we have to get in to see a doctor. So it's not having a little fever that kind of waxes and wanes throughout the day, and the child is up and running around. I mean, they look sick when they come into the ER. We know from across the room that they're very, very sick.
In all the years I've worked ER, if mom and dad think the child's sick, then they gotta pay attention. That's really what it boils down to.
And any rash on the soles of the feet or on the palms of the hands need evaluated. And then even this rash, if you get it, it's not blanchable. If you put a clear glass on it, it doesn't go away. It stays red. And anytime, any rash, at any time that you have that is not a blanch like that, we want to see it.
The governor has recently said that groups of people up to 250 is acceptable. What are the panel's suggestions for traveling and vacations?
I still have canceled all my vacations. I'm probably the wrong guy to ask.
Yeah, we're not doing, I mean, I have young kids too, and we always take a summer vacations, and we're camping this week. I mean, I think it's reasonable to postpone, and especially if you're gonna be around large groups of people, because all you're doing is increasing your exposure that if you can avoid and make it unnecessary, that would be great.
But if you decide that that's what you decide to do, please wash your hands at least 10 times a day, wear a mask, and try to maintain social distancing if this is what you decide to do. Please.
Okay, if I'm having a procedure at another hospital, can I have the COVID screening done at MHCC?
If the person is referred by our practitioners to this hospital for a procedure we cannot do, we will, as long as we have supplies available, we will try to get that screening done. But the key is a referral. If you self-refer, then that's facility's responsibility to get your testing done.
And so typically with our surgical procedures here that are scheduled, we're doing the testing 4 days prior to the procedure. So if you are having a procedure done elsewhere and it's appropriate, we try to help facilitate that. If you have a procedure elsewhere and you forgot to get the testing done or come in the day prior to want to have the fast testing done, you might be disappointed.
Is it true that if we don't have another case by July 1st, Carbon County will open with no restrictions?
That is up to the public health officer of Carbon County, number one. And number two,
No.
I haven't heard that, and we have a new case this morning,
Yeah.
so that might take that completely off the table.
Exactly. And the other thing is that most of the county offices have been following the governor's recommendation, as far as I know.
Right, we can be more strict than the governor, but at the very minimum, we're following the governor's
So,
recommendations.
You have to talk to the governor.
Okay, so at this time that we don't have any other questions coming through. Is there anything else that the panel would like to add before we close today?
No, just to still be mindful of this. Along with that last question, as they open things up and are more lenient as far as businesses and group settings, that still doesn't mean that this has gone away. So I urge everybody to still be careful, use or just be responsible in your actions. Once again, wearing your masks, even if you're not concerned for yourself. I think it sets a good standard to be respectful of your community, and if everybody wore a mask, it'd be great. It's not going to happen. I see less masks compared to a month ago, but if we can still be mindful of that, it's still important.
And washing your hands frequently and social distancing has been shown to be the most effective still. So I go to the store, wash my hands before I go. As soon as I get home from the store, I wash my hands again, these types of things. So I'm following all the guidelines that the committee has tried to push forward for all of us. And the thing is that, yes, the summer's here and people want to get back to some normalcy. Believe me, I do too. I'm still probably not going to a sit-down restaurant. I'm not going to a bar, too crowded. But I have ordered out 5 times as much carry-out in the last 2 months than I ever have in my life. So, just to keep our businesses supported. So, I got my car fixed today, things like this, so I'm still doing things. And I will I think probably Dr. Zimmerman's advice, taking your entire family camping alone is a good idea.
All right, so we did have one other question come through.
Oh, yes.
What is the rate of false negatives of the COVID tests you use, especially in the early days of symptoms?
So it's worst at the earliest. First 3 days is pretty poor.
Yeah.
But if they look at all the different types of tests we have, about 1 in 5. So we're 80% sensitive. And so there's still some numbers out there that will still sneak through.
Yeah.
But if they look at all the different types of testing out there, the average nationwide is 80%. So for sensitivity, we're missing 1 in 5.
And until they get a better test, this is what we have. And so this test is probably more accurate when it's positive.
Yeah, and our state lab actually was running higher than that. I think they were like 91%. So
Yeah,
if they look at all, this was a big meta-analysis. They looked at all the different types of it. So we may be even more accurate because of what we have available.
Yeah, and the states probably started at 70%, but they made great progress in improving their technique, better tools, and they're much better now. And if you look at all of our tests, no matter what tests we talk about, the quick strep, the quick influenza test, 90% is about all we ever get, if I may be so bold.
Especially for strep, yes.
Okay, thank you. Any final words today?
Hopefully that helps a little bit today, ladies and gentlemen. And thank you very much for the questions. It's good to be put on the spot. It really is. We have to think then.
Stay healthy.
All right, thank you everyone for joining us today. We will be holding these sessions once a month, so continue to watch the MHCC Facebook page for the next physician panel Facebook Live event. Thank you.